Okay, so let's start. Today, Sarah has proposed a new type of activity for the DCB Academy, which is a critical thinking in cardiology, not interventional cardiology, if I remember well. So we decided to keep the thing a little bit broader. And now Sarah will do an introduction to this new type of activity for DCB Academy. It will occur once per month. So it will be still, the organization will be for 2 weeks, normal lesson. Then we will have the complications corner managed by Rima, and then this new activity by Sarah. But before starting, I would like to present you Aninka from Indonesia. Actually, she is in Washington now. And hi, Aninka, you are in your room. Yeah, I can see.
Hi, yeah, I'm still at Tilted.
Yeah. So thank you for joining us. Today we have a new type of activity, as I was anticipating you for DCB Academy. And just now, Sarah is going to present it to us.
Okay, thank you.
Yes, welcome, Anika. Hello, everyone. Welcome to our first session of critical thinking in cardiology. And first and foremost, I would like to thank Prof. Cortese very much for giving me the opportunity to be the leader of this project. Each session, we will present a very complex cardiology case, real-world cardiology case, that will bring a lot of discussions and questions. And the idea behind the critical thinking in cardiology is to think critically in medicine. So to observe the information, to analyze the information, and to draw a conclusion based on our judgments. So it is in contrast to the memorizing by heart, like accepting what has been written, what has been said before. We need to use our mind to draw a different conclusion, because in complex situation, we are under pressure, we don't have time, we need to be very fast and be very skilled in this critical thinking skill. So we need to practice this skill, and we can practice this skill in this series of critical thinking in cardiology. And today we have the pleasure Dr. Sandy from UK, who will present one of his complex CTO cases, real life cases. And we have Dr. Wojciech as a challenger of this session. Thank you all. Dr. Sandy, please, we are all
Thank you, Sarah.
ears.
So, thank you, Sarah, for having this great idea and for managing this, as usual, in a perfect manner. So today we will have the good guy, which is Sandeep, which will present us a complex case. Specifically today, it will be a CTO, and Wojciech will be the critical part. So Wojciech will be the bad guy. Sandeep, please.
Yes, thank you so much. I need.
Yeah. Now you should be allowed to share it.
Okay, so the screen. Can you see?
Yes.
Okay, thank you so much for the very kind opportunity. It's a great pleasure to connect with you all virtually. And so today I'm going to be keeping this case very interactive. I'd like to hear from you. Those who do CTOs or those who don't do CTOs, it's still an interesting case, very, very interesting case. In fact, we have submitted this case at the EuroPCR, some of my fellows presenting. So let me give you a background. So this is a 58-year-old man with crescendo angina. So in 2020, he had an angiogram, but before that, obviously, his risk factors are diabetic, smoker, and high cholesterol. Good LV function, valves were fine. So the angiogram way back in 2020. So you could see it's June 2020. So you could see that's the LAD, which is blocked from there. Can you see the arrow of my hand?
Yeah. You can see it.
So that is blocked there. And the right coronary artery has got no significant disease, but you see there's a collateral from the right ventricular branch, or the marginal branch, very tortuous epicardial collateral to the LAD. So LAD fills all the way till here. So it's a short occlusion, okay? So before I proceed next, what everyone would do here is a relatively young chap. I know these days we are questioned about doing lots of PCI. Would anyone go for a medical management here first, and then maybe...
Okay, so can you remind us which is the age of this patient?
58.
Okay. So we have a young patient with angina that is worsening, with a total occluded mid LAD, a good RCA. The LAD actually is a big one, which is going above the apex of the heart. The circ seems nice, maybe some disease, but I cannot see here from this view. But okay, so single vessel disease, specifically symptomatic, with our eyes that are looking at a pretty nice stamp for tentative of antegrade approach, and then also possible collateral flow epicardial for a retrograde approach. So Wojtek, which is your impression about this?
I'm really sorry, but I have a problem with connection, and I did not see the
Can you see it now?
I'm just sorry. Right now I can see, but for last 3 minutes.
This is the only one. No. As I said,
this
is a symptomatic patient, young patient, symptomatic, one vessel disease, CTO of the LAD.
How old is patient?
58.
58. So, and there's the CTO of the LAD, and what's the ejection fraction of those patients, and what's the Euro score of those patients? Do we have any such data?
So LV function is normal. So there is viability in the LAD territory. Now, obviously, I've not calculated the JCTO score, but we can calculate here. So one, it's not calcified, it's not tortuous, it's a short occlusion, and no previous attempt. So if you take all this, the JCTO score basically calculates all this, the length of the lesion, calcification, tortuosity, and any previous attempt, failed attempt. So obviously none of them are here. So it's a low JCTO score.
So we have low GCT score, and we have only LAD occlusion, 50 years old gentleman. So we have two possibility for such of the patients. One possibility is to perform the CTO of the LAD, which probably has a good with good results. And the other possibility is to transfer the patient for the big operation for the to our friend's cardiac surgeon. However, as we
come on, Wojtek, how can you say that?
No, I don't. I say what
we
kind
have a
of
syntax score. No, we have a syntax score of 6.
All right.
So this is for me. I would never consider cabbage. Maybe, as Sandeep has said, you can consider medical treatment. For me, if you are not an experienced CT operator, I would never consider also that one. But that's a possibility. But cabbage here, to me, really makes no sense.
But it hasn't got a sense. I agree with you. However, I say what kind of possibility we could have to have the blood flow to the LAD. So those two possibilities we have. However, in young patient when the patient is in the hospital, where is the possibility to open those LAD? The option is one, to open those vessels by PCI, the CTO. So this is the one possibility for such patients.
I would like to ask the opinion of our Asian fellows. So, what would you do? Bharat, Vakas, Amit, Aninka?
Yeah, thank you very much, Dr. Professor. To me, this is a low JCTO score, and Sandeep is very right. But there is one thing which Wojtek wants to
we can see your beautiful daughter.
Thank you. Yeah, accordingly, because for such patients, because he's definitely a middle-aged man or young man, I want to have one chatting with the cardiac surgeon in this way that if we stent this vessel, then from future revascularization, this is a potential graft site for lima. This is the point I want to discuss with the cardiac surgeon. Otherwise, nothing, any compulsion to send this patient to cardiac surgeon in terms of JCTO score or in terms of the low syntax score. This is definitely a PCI case and straightforward case to me.
Yeah, but why would you discuss with the cardiac surgeon now?
Because
you know, guidelines.
Yeah.
No. But let me finish. Guidelines do not ask you, even they are pretty conservative, the European guidelines, so to call in this case for the cardiac surgeon. There is no indication. Unless you say, I don't do CTO, okay, in this case, you can go there. But what I'm saying, this is a good case for lima, I agree with you, after failure of stenting. So why do you call the cardiac surgeon now? You can call him if you have restenosis, an occlusive restenosis in a second moment.
Yeah, you're right, Professor. This is what I have evidence with me, because one of the vessel I fixed like this during my elective PCI case. After that, the patient came again with ISR after 6 months. Then I discussed this case in the cardiac meeting, in our heart team meeting in our hospital, local hospital. And the surgeon raised the point, why didn't you check for the cardiac surgeon? Because this is a potential lima site. And most of the surgeons, some surgeons are trained enough to do the stentotomy later on. Some surgeons are not, especially in some hospitals, they are doing stentotomy and doing the lima. And if they are after the first session with the stent, then some surgeons are not trained with the stentotomy. They said that this is not, they have no option for lima.
So thank you. I'm learning something really, truly. I didn't know. But in Europe, I wasn't aware that there are cardiac surgeons doing stentotomy. In the UK, Sandeep?
No, we don't do that. See, the thing is that I think you made a very good point. I think first let's start with Bernardo. You made a very good point about this type, what is it, LAD, which wraps around the
recording in progress.
You see that it's almost wrapping around. I think its point is valid, Bernardo. You know why? What Mohammed is saying is that if you end up putting a full metal jacket here, then it precludes surgery. But we know with our experience, we won't do that because we use DCBs and things here. Yeah. And also, Mohammed, if you look at it, this area is not diseased. I mean, visually, it doesn't look diseased. So exactly. Even if I want to stent here, I don't think I'll put the stent till here.
You put a short one, exactly.
Yeah, so which means you still have the lima for the future.
Yeah, exactly. But I only want to discuss with the surgeon that if what is his opinion. Otherwise, my decision is straightforward. This is for PCI case, according to school.
Yeah, but if the surgeon says they want to graft it, what would you do? They will never say no for this. They will. For them, it's like a type A lesion.
Yeah. You're right.
Aninka, yes. What would you do here?
Thank you, Dr. Cortez. In my opinion, if the indication for PCI case for doing PCI is clear, I mean symptomatic or the ischemic burden is high, because this I think is still in the distal LAD. So yeah, but if we perform PCI, I think it's doable. Yeah, but also considering the position, so we have to save for in the future for the lima LAD. But PCI is doable, I think, Dr. Cortez.
All right. So if there are no additional comments, Sandeep, please, what did you do?
So we decided to do PCI, otherwise I wouldn't have been presenting this case.
Of course.
If this was a surgical case. So we started with the microcatheter Corsair and a Gaia 3 wire. I normally take a Gaia 2 or 3. I never take Gaia 1 unless it's a soft occlusion. So always do a dual access.
So here your approach to this type of CTO is to start with a Gaia 3. That, you know, there is no rule, of course. So there is what counts is the experience of the CTO operator. I think that in other centers, they could have started with a Gaia 2, maybe, and then upgraded to Gaia 3. But there, you know, I'm encountering a lot of centers that prefer to start with a polymeric wire, tapered one like Fielder XT.
Yes, that's my
either A or R. So in your opinion, so in your experience, you start usually with this type of CTOs with a Gaia.
Especially if the cap is blunt. and I don't normally take XTA wire because it won't it won't find any channel. Polymer jacket, yes. For example, Gladius, sometimes I use it because Gladius Mongo, that's something which is good because it's got more tip load. I use it, but here my first go-to wire has always been Gaia wires because I've been now doing it for 8-9 years. I prefer Gaia. Somehow for my hands, I feel Gaia is okay, but again, it's like what my mentor said is pick the wires which you regularly use and stick to it. And, as I said, you could easily start with a Gaia 2 here or Gaia 1. I take Gaia 2 because my only concern with the Gaia 1 is that Gaia 1 is so soft, it to go subintimal if there is a resistance. So whereas Gaia 2 has got more penetrative power in 3. But equally, if someone wants to take Gladius Mongo, which is also a right option here, as just mentioned by Bernardo, because I've seen a lot of American operators go with a Gladius Mongo.
Okay.
So you could see the wire. Obviously, we always have to have a dual axis. With the dual axis there, you could see the wire is probably deviated into the subintimal here. So obviously, what I did not show was that we started with the Corsair microcatheter and then we changed to a Sasuke, which is a dual lumen catheter. So which is basically what we're doing is a parallel wire. So obviously, the first wire went subintimal, so we used that as a landmark and took a second wire. And which is now going more out side, so onto the lateral aspect of the first wire.
What is this, the second wire?
Gaia 3.
Okay, not a Gaia 3. Okay.
So we do a orthogonal view, which is cranial, just to see whether we are going in the right direction. And then, of course, we push the wire. So obviously, this wire was here, but then this is the wire now, which I'm trying to get. And then I was checked in multiple views, and I was able to cross into the distal true lumen. You confirmed, obviously, with contralateral injection. After this, we did a ballooning. So we took a long NC balloon. So this is not a DC balloon. So this is what I think Bernard and me always discuss, that if you have a chance to use a longer balloon, please take a longer balloon because it avoids multiple inflation. So this is just
an AccuForce.
AccuForce
balloon.
I always use AccuForce.
The only one. Yeah, it's the only one doing such long non-compliant balloons.
No, even NC Emerge, they do it. NC Emerge.
Emerge now it's also 30.
Yeah, they also do it.
Okay.
So long NC balloon, and this is the post pre-dilatation. Okay, so obviously, if you're a DCB operator, you then now decide what to do here.
Of course, Sandeep, at this stage, after removing the first out of the lumen wire, he also exchanged the Gaia 3 with a softer wire. What did you use here? A Sion? What is it?
I use a Sion blue. If it's a calcified, I tend to go for a Sion extra support or even a Grand Slam. But because it is not calcified, I just took a normal Sion blue wire, which was already open for the when you start the case to put a wire in till here. So you could see it's nicely looped. So it's nicely in a safe position. I've pre-dilated nicely. And of course, I did an IVUS. So I'll let this IVUS play.
So all of these steps are important for understanding how a CTO procedure, which is an elective case, you're not saving the life of this patient. You should be very keen to not to do potentially harmful things. So exchange the wire. When you can, remove the wire with a stronger tip or the one highly hydrophilic and polymeric, which can go distally and create a perforation. And then the other lesson I think that we can take from this case so far is the usage of imaging, because you didn't need imaging till now, but now, yes, because you want to understand how, if you have some calcifications, because angiographically it didn't seem, but sometimes you can have surprise, how is the real vessel lumen, how much is the atherosclerotic burden, and all of this important information. Wojtek, which is your point? You should be more critical. Try invent something to say. It's difficult now.
Why did you choose the IVUS instead of OCT?
It's just, I sometimes mix and match. So some days I use OCT, some days I use IVUS. For a simple case, I tend to use more Volcano or Philips. because it's plug and play. It's very quick to prepare, not like Boston or a thing. Because in this case, as Bernardo said, unlikely there is calcification because angiography didn't appear. So what I'm mainly looking at here is the length of the disease and the diameter of the vessel. So that is why my main I aim for the IOS, and also to find out whether I've gone subintimal at any point. Because I don't know whether Bernardo can comment on this. If I'm in a lot of subintimal space, I tend not to use DCB, because in the CRT meeting, even Bruno Scheller made a good point that if you place a paclitaxel balloon in a subintimal space, there's an increased risk of ectasia and aneurysm formation, because paclitaxel is more a cytotoxic drug. It causes a necrosis of the muscle. So if this was subintimal, then I would be more inclined to put a stent in those intimal segments, subintimal segments.
In fact, sometimes with the Gaia, it can happen that you, or not only with the Gaia, that you get out from the lumen and then you re-enter, but you don't know, because the vessel, like in this case, is straight. So only imaging can tell you if you get out and in. Okay, yeah, I make the point of Bruno. But we still have Cirrolimus coated balloons, which is not toxic into the media.
I agree. So, see, the thing is about here, the IOS, this area is completely free of any significant disease, maybe very, very mild athyroma here. And the vessel is 2 millimeter.
So what, you are here distally, where are you?
Yeah, so just start from distally, and I will just forward it. So you could see there's not much disease at all. So remember, I think someone made a point of Lima. So there is all this healthy zone. So this is all probably underfilled. So maybe this is a big vessel. So surgeons can easily graft. So I think the athyroma starts probably, so here.
Yeah.
I'll play from here. So that's supposed to remodeling of the LAD there. Yeah, between 1 o'clock to 6 o'clock or 5 o'clock. And then here, and see, this is not subintimal.
Yeah, this is true lumen. Yeah.
True lumen, you could see it here. I know volcano is not great, but you could see. But this is after the balloon dilatation. So of course, we have done the ballooning here. So see here, it becomes.
So you use which was the size of the balloon, the largest?
2.5.
Okay.
You took the NC balloon for pre-dilatation or just?
I prefer NC. I know Bernardo prefer semi-compliant. I prefer NC because I can go high pressures, and so again, it's I don't think so there is any evidence to say one or the other. It's more of a personal choice and experience.
Yeah.
So okay, before you go ahead, I would like to understand which would be the next step by some of you who wants to take the podium and tell us what would you do now?
Some calcification, very little. Okay.
Yeah.
To me, I just because this is a very good pre-dilatation results, and these are very low calcium, and there's no dissection I have seen so far. So this is a good case for DCB. This is very good case for DCB.
But what would you do now at this stage of the angioplasty? Next step.
Next step, I just because the only thing is that the vessel distal size is small. It's a 2 millimeter vessel. So this thing is, I don't want to put the small diameter stents in the vessel. So
no. But Vakas, look at this. So this is probably around the occlusion. The vessel distally is, as Sandeep said, is really hypoperfused. So probably within the future, the week it will grow up, but the atherosclerotic burden was very low. Here, the vessel is not a 2.0. So I'm not saying that we should use a DS, of course, but here the vessel is 1, 2, 3, 4, media to media, where the occlusion was.
The occlusion is, I think, this thing needs to be some co-registration, because this is a guess point. Angiographically, image must be co-registered with that point, where there's a puncture point of where Dr. Sandeep punctured the vessel with the Gaia.
But the next step, you remove the probe of the valvus, and then what you do here? I'm really curious to understand which would be your approach.
I will after this, I will give some nitrates, more intracoronary nitrates, to look for more peridilatation, and then I will do the re-imaging again to look for if there is any growth in the vessel or not. and then I will proceed further according to this is my strategy.
And what would you do?
I will give him 200 or 300 mics intracoronary
No,
nitrates.
after that, okay, it's the same.
After
the
that,
vessel is the same.
After that, if the vessel is same, then to me, this is, I will take the small, same size DCB and just do the DCB and leave the vessel.
So for you now, the lesion is prepared for the final treatment, either the CB or DS. Are there other opinions on that?
Dr. Cortez.
Yes.
So I think maybe we can proceed with maybe cutting balloon or scoring balloon. So we have controlled dissection and predilate the vessel more, and the DCB will better
the drug will be better delivered.
Yeah, I think that Tanika said something that I agree with, which is, here we have some atherosclerotic burden. I didn't see it very clearly, also the more distal part to this, but here, there it is. Yeah, okay, thanks. So, yeah. And I think that we need to do some more, I would do some mild atherectomy by means of cutting balloon. I have to admit that so far, until 1 year ago, I used a lot of scoring, but then I came back to cutting in this type of, highly heavy plaque burden. But so far, lesion preparation here is not enough for using a DCB.
Yes.
Okay,
because we don't have an dissection, and the better outcomes with DCB are the patients or are the lesion when we have got dissection. So it is the reason why we should use scoring or cutting balloon to perform the dissection, and later on to perform again intravascular imaging, and later on to do the PCI with DCB.
Yeah, so I think here I didn't mention the step here. Obviously, I give a lot of intracoronary nitrates before I do the IVUS. So this is post intracoronary nitrates, and the balloon we had taken actually was 2.5 and 3.0. So it was like two long balloons, 2.5 and 3.0. So I mean, look, I personally felt we have done enough preparation. I didn't. This was done in 2020, where I was not using much scoring balloon before DCB. Even now, I mean, there is no data to support it. But yeah, I have it. But if it's calcium, I use it. But if it's not, I think the balloon was expanding. So anyway, in the interest of time, I'll move. So essentially, what I did was took two long DCBs here, 2.5 by 35, and then maybe 3.0 by 30 or something.
But one inside of the other. So you gave a double dose of drugs.
Yeah, I think maybe it's not projected very well, but it's I had used it till here. I think wherever we did the marker from the fluoroscopy where the atheroma starts, and then we did we had a big overlap of the DCB, and this was
and
a
which
paclitaxel.
DCB was it?
It was a sequent, please.
And this is the final result, yes?
Yeah.
Mm-hmm.
So Wojciech, comment on this, the last two parts, so the DCB usage and the final result.
I totally agree to treat such patients with DCB. However, we have TIMI2 flow in such lesion, and there's in the seventh segment, there's kind of there's the lesion after that. It's the slower flow in the angio. Did you perform maybe any control angio of those patients?
Yeah, I'll come to that, but I think you made a good point about the slow flows. This is sometimes I see with the sequent please balloons, because a crystalline paclitaxel embolizes, and I see more often in STEMI patients. So in STEMI, I'm now almost like a sirolimus balloon user. But here, this was in 2020, we were still using a fair amount of paclitaxel. Even now, I use a fair amount of paclitaxel because of the data, but that is probably why you have this slow flow. But I decided not to intervene and do any more ballooning and jeopardize the result. Yes, there is some dissection.
Who is disagreeing with this point of Sandeep, meaning that crystalline paclitaxel may lead sometimes to some, impaired flow due to distal embolization. According to your experience, of course, because the data from the literature are not very clear on that. So I don't know if Bharat is still here. Do you think that this could be sometimes an issue with a paclitaxel coated balloon? You are using the sequent, please, if I remember well.
Yeah. I've had it, but it's mostly with the longer balloons. So if you're using a 40 or 30, I find then you might get that. With
But this
20,
was a 40 and a 35.
Yeah, so I think
One
because it's
35, 140.
long balloons, I found quite similar, where you do get a little bit of no reflow or slow flow, especially after you've delivered the drug, and you've the very next shot when you do the the test shot. Yeah, it seems to be slow, but it gradually improves over time, I think.
So your opinion of those slow flow is that because of the drug which has been covered the balloon? So you think that's the reason of those slow flow?
Yeah,
in my
opinion,
opinion,
I don't know whether it's causal. There's a difference between causal and kind of just observational association. So I've kind of noticed, especially if I'm using a 40 length, then it tends to I tend to see it. But if I'm using something shorter, even if it's sequent please, which is a crystalline compared with agent, I don't really notice that.
Okay, but I think that my initial suspicion after this case, where we didn't see really, a lipid-rich plaque, all of that, I agree with Sandeep. But I would suspect an embolization, since he used two very long paclitaxel coated balloons with a crystalline formulation.
Yeah, but I don't know how much of this matters clinically, because we have to prove that whether it's causing any problem. But anyway, let's see. So obviously this is a long case. Let me just go on, if that's okay.
No, but this is finished?
No. This is the interesting bit. So check angiogram, as Wojciech said, we did a check angiogram at 2 months. Okay.
Lumen gain.
Look at the lumen gain, yeah. So this may not be related, because we didn't use any paclitaxel here, but this is because of the flow in the artery. It makes the vessel bigger. You can easily put a 3mm stent if you want here. So certainly there is remodeling here. So obviously, if you compare the two, you'll see the difference. So this is the post procedure, and this is the follow-up angiogram. So everything was happy. We were so happy, very pleased. I showed this case in a meeting, showing how the remodel happens. And then the patient went home. This is 3 months post-procedure. He represented in 2023 with more pain. Okay. Now, at this stage, he stopped smoking. He's not smoking anymore. So the angiogram shows it's blocked again.
Wow.
Did you perform imaging?
Post DCB, no, I don't normally do it. But
the same place.
Same place. But the problem here is this. Have a look, Bernardo. This area is now, before it was filling all the way till here.
Yeah.
But now there's not much filling. Someone has some background noise. Maybe if you can mute it. Yeah.
So the patient, you said, had angina. So again, no acute coronary syndrome here.
No, it is more of a crescendo angina.
Okay.
And so we went back to open this again now. So we took pictures again, same place as you said, the plaque. Okay. So this time again we started with Gaia 3 and Corsair microcatheter. And obviously you spin a little bit, you see the cap is a bit tough, and then it gives away. So we we checked in the other view, and we were very long away from the lumen. We don't know yet. So we made more progress. We spun the Corsair a bit more in, and you could see here it's not looking great. It's close to the lumen, but it is not. Then we advanced the wire a bit more, and here you see it's giving a feeling that it is intimal, but it is subintimal because the wire is not advancing anymore. So then we took another view, which is the RAO cranial. Okay, so you get a temptation. It is in the true lumen, but every time you spin.
But why didn't you change? At this stage, I would have changed the wire. I would have removed the. You don't need a Gaia 3 there to re-enter the lumen.
No, I think it was not luminal. It was probably subintimal from here itself. You will see in a minute.
Yeah, exactly. But I would have used another wire for this reason at this stage.
Yeah. So we tried to re-enter, couldn't. Then we did a parallel wire. The same problem. It just goes subintimal. I could not catch the lumen. So we tried for, I don't know, 15-20 minutes parallel wire. So
you are saying that you took that epicardial route?
Yeah, so I was going to ask what people would do here, because to do a re-entry here with the Stingray with such a small amount of vessel caliber, in my hands it never works. I'm very bad at Stingray.
What about
Wojtek? Yeah. What would you do here?
So we are not in the lumen.
It seems not.
Indeed not. And so for sure it will be very difficult to engage to the true lumen when the wires are not in the lumen right now. We also have good flow from the RCA. Did you consider to go to the retrograde from the RCA?
Yeah, but this is an epicardial route. And a very tortuous one. So the risk of perforation here is very high.
Quite
yeah. In my opinion, I would insist here with an antegrade approach. Maybe I would have taken IVUS, removing one wire, and try to understand where the wire is getting out the true lumen. And then try again from that point with another wire. Maybe give an attempt for 15 minutes on that.
Yeah, I mean, we tried because, I don't know, I mean, you're right. I mean, epicardial, I only go as a last resort because it's something which you're right. I mean, having said that, I've done quite a few epicardial now. So I mean, I won't hesitate taking it if I have to, but that won't be my first choice or even second choice. I try septals and everything, but here there's no septal. So anyway, let me go a bit more. So essentially,
one thing more I just want to, at this stage, can you try the Carlino, because nowadays Americans are using so much Carlinos in their cases.
Carlino is a pure violence.
Yeah, I think it's a very crude technique, and I don't do that anymore. Just one second. Hello.
Yeah. Any other comment from Bharat?
But
I'll call you back in 10 minutes.
Or Krupal?
One of my comment is in such situation, we can choose the way, wait 2 months and again try to
this is a good option.
Open
as well.
That's what I would have suggested. You stop here and you kind of come back, let it heal, and then come back, and you might see a track and be able to enter the true lumen. Then
it's like an investment procedure.
Yeah,
exactly.
Yeah, I agree with you. Look, I decided, you know, when in my CTO practice, I go antegradally. If it doesn't work, I try retrograde at the same time. But of course, if it's causing problem like radiation and patient discomfort, I stop. So anyway, in the interest of time, I'll move. So I decided to go retrograde.
I knew.
So I've taken a Corset microcatheter 150, and this is just to start with the Sion route to start with. But then I exchange straight to CO03. So you see here, that's a CO03 gone there. And then I've taken a microcatheter to release those loops. That's very important when you're doing epicardial. So you release those loops by. Is
there anybody that would have used another type of microcatheter in this epicardial route? No,
I think good point. Caravel is something which we use, but I mean, sometimes I use, if it's calcified, I use Corset, but here you're right. I mean, because I could have used the Caravel, but for me with the Caravel, sometimes it's the way it comes back. Sometimes it milks out, whereas Corset is more meaty. So it kind of gives a better support when you're taking wire out, it won't milk out.
Your wire is CO3 in this case?
Yes, always CO03. Epicardial,
Yeah.
I would never touch without CO03.
Okay.
Before the CO03, I used to take Fielder XTR. But since the CO03, I don't take anything other than that because it's such a good wire. And the trick with this wire is don't push the wire. Put a gentle forward traction, and it goes on its own with the pulsation. So it's like every cardiac cycle, it milks forward. But you have to put a gentle forward traction.
Yeah, I agree. If using a polymeric wire, mostly tapered like XTR, despite the tip load is low, but the penetration force is high, and with this tortuosity, if it gets stuck into a bend, it could create a perforation. So SUO03 is the best choice here.
Yeah, and the thing is to make sure the loop has to be taken out. Otherwise, you cannot move this wire anymore. If you try to move the wire with all these loops, it'll perforate. So this there, and then we got the corsair there. So then now you take a next bend. So you just again gentle forward traction. You see that?
Yeah.
Okay. So then again, same. Get the microcatheter so that it takes that loop out. Okay. And then you take the microcatheter again. So here you see I'm going with the microcatheter forward. And then I release the loop. Okay. And
your guide is 6 French on the right side.
7 French, always 7 French.
7 French, okay.
Okay, so here, look, it goes into the distal RCA now. So then you get the corsair in. So now here, this point, the hybrid operators knuckle the wire and then try to do reverse cut. But my practice is to try retrograde wire escalation. So I took a Gaia 3 back on and I got the Gaia 3 here. So I could do a reverse cut here if I want to, but I decided maybe let's see how much the wire goes.
Yeah,
so
I have to say that Sandeep has learned from the Japanese school, so he would never go out of the lumen. So just as a last option.
Yeah, I agree. So then I spun, this is Gaia 3, I spun the Gaia 3 and then Gaia 3 went here. And I took a picture and it looked promising. Now you should not assume that you're in the true lumen. Okay. It's likely I'm in the true lumen, but you cannot assume. You could be still in the plane. So you have to do an IVUS. So I put an IVUS probe on the antigrade wire.
This is a very important point, Sandeep. Here you have to be sure you are in a proximal LAD. You are no more in the distal one. It's already occluded. What can you do? Here you are in a proximal LAD. There are branches arising from here. So if you are doing a PCI now, you have to be sure to be in the true lumen with a retrograde probe, with a retrograde wire. So it is mandatory here to do IVUS.
Yeah. So that's the IVUS probe. I'll show the IVUS. So this is the IVUS within the proximal LAD, and you see the wire here at 5 o'clock.
Yeah.
See, so which means this confirms I'm in the true lumen. So this is the retrograde wire. So I'll play this again. Yeah.
Yeah,
so
this is a Volcano IVUS. You want to comment on this? Yeah. Okay. So
then normally I use a guide liner to catch the wire, but sometimes I try because I want to save the money. Sometimes it's calcified. I take guide liner because I may need it for the procedure, but here it's not calcified. I didn't use the guide liner. So I don't know if you saw it here. The wire now goes into the antigrade guiding.
But which wire? You have already exchanged it for.
Yeah, I think it's just either some RG4. Yeah. No, RG3. RG4 is after getting RG4 is after getting your microcatheter in here. Okay, so this is just a normal wire trying to enter the guide. Then I have to take the corsair microcatheter. So once I go here, I'll show you the next picture.
Yeah, but this is not a Gaia 3 anymore.
No, not Gaia 3.
Okay.
So the wire is now in the antigrade guide. So I take a balloon, I inflate a balloon, and I jail this wire, and then get the corsair into the antigrade guiding catheter. You'll see here now the corsair is now being pushed. The balloon is inflated here, so it's kind of holding the wire. So it gives a nice anchor for you to get the retrograde microcatheter.
So this is a very delicate moment because all of this is passing through a delicate epicardial route. So you have to be very gentle while you push and rotate the microcatheter here.
That's a very good point. Very good point. I agree. Now here you see, this is the next step. So what would anyone do here is that the normal practice is you got your microcatheter here, then you take an RG3 wire, externalize, then you work on the retrograde wire, RG3 wire. I normally do that in most cases, but if it's an epicardial, I'll try and do a technique called tip-in or a rendezvous technique. So I'll just explain this to you. Essentially, this microcatheter, which has come from RCA, and I now, sometimes I bring in a microcatheter, but sometimes I just take a fielder FC wire, which always goes into the outside of the guide. So just watch this now. So that's the fielder FC wire comes in now. I'm trying to get into the true lumen. Look here, it comes now, goes here.
Yeah.
Easily. So watch it again. So this is called rendezvous technique. It's not that rocket science. It's very, just have to try. You'll go. And good thing is don't put a bend on the fielder wire. Keep the wire straight as much as possible so it enters the. And you could use a microcatheter to make it more coaxial, but I just try sometimes. You just try it works. And when that happens, then you can milk your retrograde microcatheter back. You see, watch here. It comes back here. Now I can work on the antegrade. I don't need to worry about retrograde now. So then, of course, I balloon. And I did an IVUS. This IVUS is interesting. What's this IVUS? I will not comment, but I want you guys to comment. This is on an antegrade wire now, after that. And you will see.
So Wojciech, comment on this IVUS.
So, what do we see? It's not. It's running, or it's.
It's running.
Yeah, it's running.
Yeah, nothing to say now so far.
There's no calcium.
Yeah, so distal wire is healthy like before. But can you now watch? Can you watch here? Watch here in a minute. You'll see a crescent shape, which is basically showing that I was subintimal before.
Here we go. Yeah. You can see it clearly.
Okay.
See that?
So because you have a microcatheter, so you have the
long.
hole. That's the hole created by the previous microcatheter going antegradely outside of the lumen. Very nice.
So I was actually, Bernardo, subintimal right from the beginning.
Yeah.
So this I was sure is a great thing because I was subintimal from the beginning. So even if I had re-entered distally, it would all been all subintimal space. Luckily I didn't enter because you don't want to have a subintimal space stenting in LAD, losing all the diagonals and the septals.
Yeah, if you had done the IVUS at the beginning, probably you would have understood immediately this.
Yeah.
That's very nice picture. You have published this case. It's very nice.
Yeah, so we will have to write this up. And then this time I used a stent here because I failed DCB before. And I used the magic touch from here all the way to the mid to distal. Okay. And then I repeated the IVUS just for the stented segment. I'll just, in interest of time, I'll take it quickly. So this is all DCB segment here. Here, DCB segment, and then the stent. Yeah. So stent is okay. It's opposed.
So if you have such results right there, so we have...
Can we see the angel, the final angel? Okay, nice.
Now, I was worried that this may close off again, like 3 years later. I told the patient, can I do a check angiogram, maybe 8 to 3 months, because I want to make sure if there are any signs of re-narrowing, then I would have sent you for a bypass. So patient came for a check angiogram. Oh, sorry, this is a check angiogram. Maybe I made a mistake. Yeah. So this is a check angiogram. So this is check angiogram. Patient's completely asymptomatic. Now the question I want to ask you all, this is 3 months post. Now, should I image this again at some point in 6 months or 1 year, or shall I just go with the symptom guidance?
Symptoms, and maybe you can do a CT scan in 1 year.
CT, yeah, you can consider CT angiogram.
That's a good idea. That's my plan. CT angiogram.
But you think you're sure that CT scan? I think in such patient we could also see as a SPECT for those.
But SPECT is not visualizing the artery.
I know, so but we have the situation when we have the stent. The stent is 3-0, and we could have the problem with the information, or do we have an instant restenosis of the?
In my opinion, if you have a good CT scan operator, patient is quite bradycardic. With this stent, you can see it easily how is the lumen.
This is the crucial point.
Yeah, normally greater than 2.5 with the current machines, you should be able to see.
Exactly. I will do CT scan here for sure.
Yeah, exactly. My plan is to do a CT scan in 9 months. And of course, if this starts narrowing, then I'll have to go for a lima. At least I left some space for surgeons to put a lima.
So we've actually, interesting, we've actually done a trial doing CT scan follow-ups at 2 months and 12 months for our post-ACS patients with both stents and DCBs. So you can see very nicely a passivate trial. So quite nicely, we're going to publish
you have published it?
Oh, we're going to, yeah.
Okay, when you have the publication, if you want to share it with us,
Yeah,
it's interesting.
Yeah, it's quite interesting. And we can see the majority of them, we can actually see. Anything greater than 2.5, you can see quite nicely.
What is the name of the trial, Bharat?
No, it's not published yet.
We haven't published it.
Okay.
The Passivate is the is the study, but we haven't published the results yet. But I mean, we're looking through all the data. It's quite nice, actually.
Have you also used some DCB in this trial, or it's only?
Yeah. So all ACS patients, including both DCB angioplasty as well as hybrid and stents.
Nice. Share with us, please.
So after that situation, when we have DCB failure, we could say at the after the first step, don't you think that during the first PCI we could choose the short stent in the middle part of the LAD?
I agree with you, but that is life. Sometimes stent
that
fails,
is life.
DCB fails.
Stent fail, DCB fail. But the lesion preparation probably was enough, and the final result was good. So I'm really surprised, I have to admit, because usually when you have DCB failure, it's coming a little bit easier to treat. So it doesn't come back with this total occlusion, but in life everything can happen.
Exactly. And the other thing is that we always say the DCB failure usually in the first 6 months, 1 year. The late catch-up phenomenon is not that much seen in the DC because you showed in your recent paper or recent presentation. But here, look, it's blocked off in 3 years. So I don't know.
There's one more thing. Just see at the final result that there's a still diffuse pattern of disease in the distal vessel as well. So
but you see, on the IVUS, there was not much disease. It's maybe it's just I don't know.
There's a bit of bridging there, isn't there? There's also a bit of bridging there, Ro.
Yeah, maybe some element of bridging there, but anyway, so we have given the best shot for the patient. Let's see. I hope it remains asymptomatic. And
very nice case. Very nice.
Yeah.
Interesting.
Thank you, Sandeep.
So I suggest if you're doing a retrograde with epicardial, try and do this tip-in. It's called tip-in technique, which means you avoid messing around with the epicardial too much.
In my opinion, epicardial should be the last, really the last
100%.
frontier because of the risk of complications. But this case went very, very well, and we got a lot of interesting lessons from this. Really, I appreciate this. So I think we can close this part of the lesson and go through a little bit on update on the scientific activities, if you agree.